Hi, I'm Dr. Matson. Today we're covering Chapter 7, Policies and Regulation Conditions Impacting Health Outcomes. And this is following the Openstacks for Nursing textbook in the Population Health for Nurses. So just as an overview, what we're going to do today, we're going to look at factors affecting public health policy. We're also going to be talking about balancing individual rights and public health interests, and this is really important for everything that is happening today. And public health initiatives, delivery mechanisms, and implications, we're going to broadly cover that, as well as policies that could affect pharmaceutical drug approval, supply, and cost. So public health policy, it comes in many forms, from legislative policies to community outreach and interventions. And as you may know, it can affect a lot of healthcare fields. So this could be from insurance, education, agriculture, and business, among others. Public health policy development intervention happens at a local level, at a state, and then national and even global levels. So most important, this focus of public health policy is really to improve health outcomes for communities, which we as public health nurses are really positioned to understand and impact change. So here are the learning outcomes for today. So you can see these different topics that you'll be able to address. And these are things you should be focusing on and coming back to at the end of this lecture. So when we think about access, cost, and quality, there are many factors that play into public policy, and this is through discussion and decisions. And most Americans access their health care through their employer's health insurance plan. So this normally covers about 70% of workers, 36% of children, and about 50% of non-working adults. The U.S. does not have publicly funded universal healthcare systems. This is very different than other countries that are similar to us around the world. And with the passage of Patient Protection and Affordability Care Act in 2010, millions of previously uninsured Americans were able to receive healthcare. Millions of Americans, so greater than 65, some with disabilities and end-stage renal disease, those with amyotrophic lateral sclerosis, so ALS, have access to healthcare through Medicare program in 1965. So Medicaid covers some low-income families and children and individuals with disability. And again, these policies are really up in the forefront of what is happening in our world today, so having this foundational knowledge is really important. So access to healthcare is impacted by technology. We saw this during COVID-19 pandemic, and what happened was that there was an increase in telehealth. So this demand increased dramatically. There are some questions that come up when we talk about telehealth in terms of quality and accessibility, and we see that healthcare cost has a role in public policy. So in the United States, one of the highest healthcare costs in 2021 was spending about 4.3 trillion times on healthcare. This is twice as much as the average cost of healthcare in other developed countries. So when we think of policy change, this is needed in order to lower expenditures while increasing access to healthcare. Some of these costs are happening through evolving payment models, and individuals are using various kinds of models to pay for their health care. There are barriers, especially in healthcare deserts, in accessing healthcare, and we'll go into that in a little bit more detail. So here you can see this is a nurse specialist at the Navy Medical Center in San Diego using telecritical care to provide remote intensive care unit. And we are going to be thinking about how these telehealth services and nurses combined can really help expand the reach of care where otherwise would not have been able to do that. So now we're going to talk about factors affecting public policy in terms of payment models. So public health policies relating to payment models may help to address problems with billing. So we think of a transition from this very traditional pay-for-service model to a payment based on the value of those services. So not just delivering them, but what is the quality? Are they working? Are people getting readmitted? So we have this value-based care and its alternative payment model. And the three most common categories of payment model for physicians are core payment models, supplemental or supplementary payment models, and organizational models. So we can see this in terms of in-house physicians, if they have private practice, and how are they getting reimbursed and paid from insurance companies. So healthcare organizations, they're reimbursed in different ways. They have prospective payment systems, bundle payment, and accountable care. So anyone who's interested in going into management in nursing, you're going to learn a lot about this and productivity, which impacts patient safety, discharge planning, and then access to community. So all of these things, although may seem broad and out of reach currently, actually really have a big impact on care in both an acute and public health setting. So recently, value-based purchasing programs have significantly changed how hospitals approach providing care. So for example, the hospital value-based purchasing program bases Medicare payments on quality of care rather than service. So in a system, if a hospital has really high post-operative infections or ventilated associated pneumonias or negative outcomes associated with hospital care, then they receive decreased reimbursement. So this is really complex, where care is provided and to whom. So when we think of healthcare organizations and we're saying that they're reimbursed in these different ways, we want to think about how this is a shift from an inpatient to outpatient community setting. And then how is this influencing who this care is delivered to? And what does that mean in terms of measures and incentives for the hospital system in providing that care? So when you're looking at HCAHPS scores, when you're looking at metrics like UTIs, when you're looking at hospital-based infections, so all of that is going to impact reimbursement to the hospitals. If patients are coming in or getting readmitted to the hospital, then that is going to impact reimbursement. So again, when we're thinking about discharge planning for patients and we're sending them back to the communities, if we're sending patients back to the communities that they don't have the support system there to help take care of what they're being sent home for, and they're readmitted and they're in a worse state, then now the hospital may have to have that cost taken upon themselves. So again, really important to see, okay, who's the case management? Who is the social worker? Where is the patient being discharged to? What is their health literacy level? Do they understand their discharge instructions? When we think of social determinants of health, okay, what is the pharmacy that this is being sent to? Is it a place near their house? Is it within an insurance that takes their insurance, right? Do they have transportation to get to the pharmacy, or are they not going to be able to get to the pharmacy and then get their medication and then now they're readmitted? So all of these things actually really play an impact in this continuum of care. So care deserts are where individuals have limited access to healthcare services. We think of this in rural areas, and maternal health care deserts and pharmacy deserts. Those are like the two big ones we can think of. And you should take a look at Imperial Valley, because we have a San Diego State campus there, and see, okay, how many hospitals do they have in Imperial County? How many OBs do they have? Where are their pharmacies? Because if you look in that, even though we have nursing students who are being trained here on main campus and Imperial Valley, there's a big difference in terms of what's available for the patients in that population. So you should be thinking about that translation. And if you're someone who is in Imperial Valley, this is really impacting you. And so then what are some creative ways and innovative ways that we can help bridge this gap in these deserts, right? So more than 80% of counties lack proper access to medical care services. These are the reasons for the care desert. So we see that there's very long travel times to get to physicians or get in and be seen. Demographic shifts, so there's decreases in population. Therefore, there's a decrease in revenue for healthcare providers. There also would be a very high number of uninsured or underinsured, or many Medicare and Medi-Cal enrollees, so lower provider reimbursement. So all of these things can be impacting why there's a care desert. So we want to think about where we can impact and change policy in order to think about these care deserts and where we can bridge this gap in these rural areas. So in care deserts, one thing that we can think about is telehealth and telemedicine for routine care. But the gap is that there are many areas still left without access to emergency, inpatient, and surgical care. Also, it requires that there is a way to get on the internet and connect for the ones that we're using telehealth for. And when we think about it, not everything can be served through telehealth. So there are some conditions that require testing in person. We can think of, looking at streptococcus. That needs to be screened for. Cancer needs to be screened for in person. So organizations like the National Health Service Corps, that's operated by Health Resources and Service Administration, which is the arm of U.S. Department of Health and Human Services. They connect rural and urban and tribal communities with healthcare providers. There's about 20,000 members to provide care to about 21 million people in the United States and over 9,000 communities. So according to the National Academy of Science, Engineering, and Medicine, nurses have a significant role in addressing health inequities. So the profession has really deep roots in community health advocacy and social justice. And the organization identifies 5 key roles to improve health equity in populations that nurses can do. One is being aware of it. So just listening to this lecture and becoming aware of it. The second one is adjustment. So where do we need to change how we're giving nursing care? Alignment. So if we think about, is this aligning with current standards? And then advocacy, you're really, as nurses, in that position to be a voice for change within the communities and organizational structures. Okay, so now we're going to talk about health as a human right, look at the implications for protecting that right, look at the government obligations and international mechanisms, as well as any tensions between individual and public health. So is healthcare a human right? This question has been long debated. The WHO's Constitution states that health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. Like we said previously, unlike many other countries, the United States Constitution does not include a right to health care. The U.S. government does give support. This is seen through Medicare and Medicaid programs, which are federal tax subsidies, and for employer-sponsored healthcare programs. We have also seen currently that there are huge cuts to these programs or changes in the program. So it's important to know those distinctions too. And then despite these programs, costs have increased. So many Americans are uninsured. And when we think about this access to care, we have to look at policies and programs that are there to support Americans. And we think of the CDC and Health and Human Services, so HHS, they work to improve population's health. So Healthy People 2030, which you guys are familiar with, includes health policy as a focus area. And then it has specific objectives and steps either in research or practice to try to move the needle in some of these areas. We think of mechanisms to protect the right of health. There are core components of the right to health, as outlined in Article 12 on the economic, social, and cultural rights. In 2018, it marked the 70th anniversary of the birth of human rights law through the World Health Organization, which provided foundational public health policy and advocacy. So the American Public Health Association, APHA, established a new human rights forum, and this is really seeking to build the capacity of professionals operating in the public health space and to move to a more human right-oriented public health practice. We think of public health nurses, that's APHAs, that's the organization. They have a key role in this to influence public health policy. And then Senate policies are also influenced through health. When we talk about balancing individual and public health interests, there is a tension between individual rights and public health. So in the United States, with its individualistic cultural emphasis, there are tensions between individual rights and public health as we see it in the news today. So some just simple examples would be when we think about tobacco restrictions and seatbelt use and helmet use, as well as mandated vaccines. So what people are saying are what is their right to take these risks, health risks on, versus what is the public health right to stay protected, as well as to reduce the burden that people engaging in these activities could have in terms of healthcare cost and delivery of care. We saw this really exacerbated during COVID-19. So that's that individual versus public health right in terms of wearing a mask, staying home, getting a vaccine. There are really 4 standards that have to be in place to recognize restrictions when it comes to this individual versus public health. So 1, it must be a necessity for government action. So whatever it is that would put that restriction in place has to be necessary and for the governments to intervene. The other one is it has to employ reasonable means. So we think of COVID-19, it may not seem reasonable, but at the time, having people stay home in place for a certain amount of time was deemed reasonable. It has to be proportional. So what is the threat? Is it very big? Is it small? So that whatever the restriction is has to be in relationship to that health thing. So again, COVID-19, we're thinking about people dying, the burden to the healthcare system, inability to take any more people on, and that made it deem that it was necessary. The government had to get involved. It was reasonable based on that because of the proportion at which it was impacting the healthcare systems and people's health, and it should avoid harm to the health of the individual. So as you all can remember and see this is just, again, showing this kind of tension between advocacy for rights and protection of health. Okay, now we're going to talk about Healthy People 2030 and those outcomes associated, health policy mechanisms. We're going to think of fiscal policy, for example, regulation, education, preventative treatment and screening, and then also think about this triple aim of population health, cost, and satisfaction. Okay, so Healthy People 2030, you guys are familiar with this public health initiative that seems to improve health outcomes in the United States. Has 23 high priority areas, and these are indicators to improve health. And then policy and programs drive and establish the mechanism by which these outcomes are achieved. So the mechanisms, we talked about fiscal policy, regulation, education, preventative treatment, and screening. So these are all the different aspects that really are driving this policy change. When we think about the Institute for Healthcare Improvement, Triple Aim, the U.S. healthcare system lags in factors related to access, affordability, and quality. The Triple Aim is a framework developed by the Institute for Healthcare Improvement, INI, that aims to improve healthcare systems performance on 3 levels. So, improving the client experience of care, improving the health of populations, and reducing that per capita cost of healthcare. So really, when we think about this recommendation, it's targeted at a specific population and system, and it's trying to measure that target population and develop what we call a portfolio of this project's work as strong evidence for change. And then this is rapidly changing, and there's testing, so this has to be adapted to the community. So for this Institute for Improvement, for this Triple Aim, the results and benefits of it are: 1, populations become healthier; 2, the individuals receive more coordinated care, and that can lessen the burden of disease and illness. It can also reduce the per capita costs for those populations that are stabilized, and the burden on publicly funded healthcare budgets, such as Medicaid and Medicare, could be lessened if there's an improvement in that area. And then the economic well-being of populations improved, especially if that allows them to return to work and to their higher quality of life. We're going to talk about the FDA and global drug manufacturing, as well as pharmaceutical cost. So here, the FDA, you guys should be familiar with this. It's a regulatory body under the Health and Human Services umbrella. It's broad regulatory authority. It's responsible for protecting public health by just ensuring a standard, right? So it's the standard of what is deemed acceptable in terms of food supply and pharmaceuticals and products and devices, especially as it relates to health. And one of the most recent FDA actions was the approval of COVID-19 vaccines that they expedited due to the pandemic. We see the FDA is part of a lot of clinical trials for pharmaceuticals, as well as things like flu and other medical devices that are screening for illnesses. So here's just that image of the COVID-19 pandemic, and this has helped you remember the FDA's role in it. So when we think about the global drug manufacturing supply chain, the supply chain consists of participants at each step of the process. It takes a product from raw materials to a finished good, and then it's sold, right, to customers. So pharmaceutical supply chains are global. They're very complex. Up to 90% of needed raw materials are estimated to come from other countries, and the supply chain's quality and safety are essential really to the United States and national security, as well as public health. So this pharmaceutical supply chain faces challenges, including visibility, rising costs, and these changes really negatively impacted by the COVID-19 pandemic. Americans spend, when we talk about pharmaceutical costs, Americans spend more on prescription medications than citizens of other countries. So pharmaceuticals are one of the fastest growing components of healthcare spending in the United States. Reasons for high drug costs include monopolies, disease severity, so people are willing to pay more for them. Research and development, it's very high to pay for this, and political power of the pharmaceutical industry. So in summary, we talked about these factors affecting public health policy and balancing individual and public health interests, as well as delivery mechanisms and implications and policies that affect pharmaceutical drug approval in the FDA. Thank you.